And I apologize, Eric, for going late.
Thank you so much, Tom and Vanessa. We have time for a few questions, and I just wanted to make a comment as well. I think you brought something up, Tom, in terms of your role, especially as a GI doctor, but overseeing patient experience. I think for all of us, we're kind of ambassadors for the field. And I think it's important, first of all, we have to be better than neurosurgeons, clearly. But I think, it's a challenging time, especially if you have a large group, is dealing not only with the patient, but our providers. I think providers are under a great deal of stress compared to any time before in medicine. And I think it's also challenging sometimes to connect with patients because, we were just talking about mailing out fit kits and things like that, but people don't really pick up the phone anymore because I think at least for me, I get like 25 robocalls a day. I think I'm on every list known. So it's difficult to connect with people. So when you have an opportunity, when you're sitting in front of someone, that's a chance to really, really get back to why we all became doctors in the first place. And patients are paying attention, and I think it's really important, like that being on stage, every moment you're walking in a healthcare facility, you're kind of representing all of your colleagues. And whenever there's one, kind of bad experience, it reflects on in the entire profession. So Dr. Dulé, take it away.
Quick question, maybe for Vanessa, is when you do cold resection of a larger sessile polyp in the right colon, left colon, doesn't really matter, tend to see more in the right colon. You mentioned using epi to control the bleeding, see your field, do it. That makes sense to me. I also saw there was in the LA Live yesterday, we had a case where they actually used injection to bring it up like a true EMR for a non-thermal method. So I haven't done that. I've just, piecemealed them without doing injection and used epi as needed to control the field and see. I just wondered if you thought there was any advantage to using Eleview or something of that nature.
Sorry. I'm glad you asked that question. What we do is we'll do half-half, so half 1 in 100,000 and half Eleview or whatever the choice of your lifting agent is, and that way that it delineates it. I like kind of having the dye underneath, and we do inject it, so we make it rise and then do cold resection.
So both, okay. And second question was the most fascinating abstract of DDW was this duodenal non-thermal.
It's crazy.
It's crazy. Yeah. So how long does it last? What are the mechanisms of action?
Yeah.
Could it work better with GLP-2 receptor agonists? In combination, they didn't say what the meds were, but that's just absolutely fascinating.
So I was reading more and more about it. Apparently punctures holes in the epithelium and it allows it to re-epithelialize. It's unclear whether it's just mucosal, submucosal, both. There's so many things that remain unanswered. So I really don't have a good answer for you yet, but I think with time we'll really get it. But it's an amazing technology. I think the one thing you have to make sure is that I always worry about the ampulla, and so you really need to make sure endoscopically you're distal to it, because you can imagine if you overlay it. So let's see which generation comes out. And the reason they changed from generation 1 to generation 2 was that generation 1 wasn't large enough, and so they were not getting the full circumferential treatment. So wish I had more answers.
Yeah, no, absolutely. And the one thing which is very, very clear is the duodenum plays a huge dominant role in diabetes. And so when we do a Roux-en-Y gastric bypass, the whole reason for that is it will reverse diabetes, very consistently. And so also coming down the pipeline are a number of new products you haven't seen yet, in which they're basically revisions of the duodenal sleeve. So you bypass the duodenum so that you can actually, not have things go through. So the duodenal remodeling, I kind of look at it as the same thing, as somehow it's addressing at the level that I don't understand. This is where I need the endocrinologist to understand all the signaling going on, but things are going on, with that. And so I think that's where you'll see a lot of the efforts coming up.
And it's fascinating because it's not even heat.
Right.
you know?
And you think beyond just diabetes, you mentioned in the abstract, there was some discussion about weight loss. So is that kind of, given, the interest in weight loss and medications, kind of like endoscopic approach to weight loss that's not like a bariatric procedure?
I mean, I guess potentially. I don't think we're quite there yet. And that was at 24 weeks. I think we need longer term data, but it's exciting stuff.
Right. Does anybody else have any questions?
I had a question for Vanessa. For the cold snare stuff you read, we talked about at LA Live yesterday about underwater endoscopy, and because that's another way to remove big polyps and do big EMRs. And but it was interesting because the people doing it there were doing it with underwater, not injecting anything, but using hot snare. And so I'm wondering, do people do underwater with cold snare, or any data on that?
No, there's no data that I know of with cold snare. So we used to use underwater all the time. That's all I would do. And it's nice, especially when you have really, really flat lesions or adhesive lesions. And the concept there was by Ben Moeller. He had an EUS probe. And what he noted is that when you filled it with water, you weren't insufflating, so you weren't thinning out the wall. So your submucosa kind of floats. So that's the whole concept, and then you can cut safely and not capture the muscularis mucosa. But I don't know of any data saying that there's underwater cold.
Great. One more question.
Just one comment, Tom. Really appreciated your talk. We all have patients that when they're about to undergo a colonoscopy, they're kind of freaking out. They're very, very anxious for whatever reason. And we do our best to reassure them that they've got the A team, we've got a lot of experience, et cetera. But one thing I found helpful is to ask them specifically, what is it that you're nervous about today? What are you concerned about today? Because different patients have different concerns. It could be the sedation, I've never been under, what are you gonna find, et cetera. And I found that when I ask them what they're worried about, and then I address that, things go a lot better.
Yeah, no, that's absolutely good. And it's kind of joint decision-making and joint involvement in involving them. And everybody's different. I think that's kind of one of the key things is you can't treat everybody the same. Treat them as an individual, say what's their individual thing going on, and it goes a long way. And what will happen is then they're going to get put to sleep, but they're going to remember what you said, and that's going to be the memory they take back with them. So yeah, he asked me about that. So that's great, Kevin. Appreciate it.
Great. Thank you both so much. And we're going to take a break now, and we'll come back at 3:30 for our last session, which will be